మీకు కనిపిస్తుందా ఎంతమంది జాయిన్ అయ్యారని?
హలో.
నాకైతే వస్తుంది. మీరు ఒకసారి చెప్పండి చూడండి. మీరు అక్కడ నుంచి చూడండి. ఇది కాదంటారా? ఇది తీసేస్తుంది. ఎందుకు ఇదే కదా? పక్కన పక్కన వస్తుంది ఇక్కడ పెట్టండి. Hi, a very good evening to one and all. So we all finished at 158 slide. I've added a few more pictures for you all, so it's more easier for you to understand. So we'll be starting from 158. We have a 1 hour session today. Very hot. I hope all of you had a very pleasant weekend. Jumping into the next week. I think most of you are writing exams today, right? Today or yesterday and day before you have your BSc exams. Anyways, all the best for all the nurses who've been giving the exam today, day after, tomorrow. Okay. So yeah. We finished last was about heartburn, that is GERD. So today we're going to talk about benign and malignant tumors of esophagus, just a brief idea about it. What do you mean by leiomyoma? Oma means a tumor, and leiomyo is nothing but smooth muscle. So tumor of a smooth muscle is called leiomyoma. It is most common type of benign esophageal tumor. So it's benign, it's not malignant. In the sense, it is not cancerous. Adenocarcinoma is the most common type of malignant tumor of esophagus. So adenocarcinoma actually upper one, if you divide esophagus as the first half or the second half, or you divide it into three parts, the first one third, the second one third, and the third. Last part of the esophagus is very notorious to develop adenocarcinoma, and the upper one third of esophagus is notorious to develop squamous cell carcinoma. But most common type of cancerous situation in esophagus is your adenocarcinoma. And what predisposes to it? I've already told you about Barrett's esophagus. So what happens whenever the patient has a lot of reflux, a lot of acidic content coming from the stomach and causing an erosion to the epithelium of the esophagus. So most vulnerable or most susceptible to that acidic erosion is your last one third of the esophagus. So last one third of the esophagus continues this acid causing issue in that area will cause a change in the esophagus. It's a metaplasia. So there is change from one epithelium into other epithelium. Normally you have a squamous epithelium, but that changes to cuboidal or columnar, and that's called Barrett's esophagus. So whenever this area becomes velvety, called as Barrett's esophagus, that can predispose to adenocarcinoma. Okay. Dysphagia is the initial symptom of esophageal cancer. If that cancer occurs at the upper one third, you have dysphagia. Even lower one third dysphagia. Difficulty in swallowing is here. And wahan pe usually they'll end up having vomiting because the lumen of the esophagus narrows down. And characteristic X-ray in the cancer of esophagus is bird beak appearance or rat tail appearance. Sureshan, so I'll show you a picture, an X-ray. So this is how it looks like. You can see here, you have a filling defect. You're doing barium studies here. Barium is entered very normally here. And here you can see the improper filling, or you can also call as filling defect. फिर यहाँ पे you have that bird beak kind of an appearance. So all this thing, what does it say here? Barium tapering indicates an outgrowth from the wall of the esophagus. There's some kind of growth in the esophagus, and you can see it is not uniform. So usually, if this kind of image you see, then you have to suspect a carcinoma in this patient. Patient is advised to avoid gas-forming food or food containing seeds, nuts, or roughage because these food items may be trapped in the diverticulum. And talking about diverticulum here, so if that patient has diverticulum, yesterday I told you diverticulum is outpouching. So you'll ask the patient to avoid any gas forming foods. Nuts, seeds also can cause gas, or if you have a lot of roughage, okay, those can also get trapped inside this diverticulum and cause diverticulitis. Anything which gets trapped inside the diverticulum, sitting there for a long time, first symptom is the patient, whenever he's talking to you, the patient has a very bad odor coming out of his mouth. So that's called halitosis. That finally, that food which is there in that diverticulum causes some kind of irritation to the diverticulum, leading to inflammation of that diverticulum. That is nothing but diverticulitis. Then you have something called Meckel's diverticulum. Meckel's diverticulum is an outpouching or a bulge in the lower part of the small intestine. Mostly it's in the ileum. The bulge is congenital, okay, may be present at the birth and is leftover of the umbilical cord. So you have umbilical cord, that leftover portion is stuck to that ileal part and that grows like an outpouching. I'll show you a picture. Complications are you can have a GERD, reflux disease, including esophagus can develop inflammation. There could be strictures, there could be aspiration of these gastric contents and aspiration immunity. Generally, if you have a diverticulum, all this can happen. So, यहाँ पे you can see this is your umbilicus, okay, and this is the ileal diverticulum. Usually, you find this diverticulum near the ileocecal valve, so this is like last part of the ileum. And you can see there is an outpouching here, there is a diverticulum here, and that is connected with the umbilicus by the uh, Purana umbilical cord. You know, this is the fibrous cord. And this is your anterior abdominal wall. So you have on the anterior abdominal wall, you have your belly button or your umbilicus. There's a cord attaching to this diverticulum. Computed tomography is nothing but CT. What does CT do? It takes images. It could be longitudinal, it could be cross-sectional images of the abdominal organs and structure. So for this diverticulum, you'll tell the patient to be nil by mouth for 6 to 8 hours before the procedure. If the CT is performed with contrast agent, allergy test has to be done. You have to ask the patient whether he's allergic to different things. Okay. If he is, then you have to avoid the contrast. If variant study is also there, it has to be scheduled after CT scans. You first do CT and then you do a variant. MRI is contraindicated in patients with permanent pacemaker. Obviously, any kind of metallic implants into your body, if that patient has rods into his body, you can't do an MRI. You can't expose the patient to a magnet. It will literally pull out the magnet from his body. That's strong the machine is. If you have never seen an MRI or a CT machine before, I request you all to go to the radiology department and have a look how the machine looks. Just experience how noisy the MRI machine is. Okay. So it's contraindicated. MRI is contraindicated in patients who have pacemaker, who have artificial heart valve, implantable defibrillators, implanted insulin pumps, and any kind of metal device in the body. So same again, patient has to be nil by mouth 6 to 8 hours before the procedure. You have to remove all the jewelry and the metallic things from the body before we undergo an MRI. And client who has claustrophobia. What do you mean by claustrophobia? It's a fear of small room or a entrapment kind of a situation where the patient starts feeling more breathless, develops an anxiety spell when he's put in a very small room without windows. It's called claustrophobia. So if because once you make the patient sleep on the table in the CT or the MRI machine, it goes inside that tube, right? So that tube can elicit this kind of a claustrophobic attack. So if such patients are required to undergo these procedures and you want them to stay calm, you'll obviously put them on a sedative before the procedure. Inform the client that knocking sound may be heard during the procedure. So MRI is a very noisy procedure. You can hear that knocking sound and it happens for 45 minutes to 1 hour. That sound can be a little irritating for the patients. You have to tell them prior that this is what is going to happen, do not panic. What is gastritis? The name itself says it's the itis of the gastric mucosa. So it's inflammation of the stomach, inflammation of the gastric mucosa. Causes are use of aspirin, NSAIDs. NSAIDs are nothing but your daily painkillers, excess alcohol intake, radiation therapy, bile reflux, and microorganisms, especially H. pylori. All these things can lead to gastritis. Gastric mucosa will become edematous, it will become thick, it will become hyperemic. Hyperemic is become red and it undergoes an erosion if it is not being treated for long. So this is your normal mucosa. As you can see here, this is okay. This is your esophagus and this is your stomach. So esophagus is entering into your stomach. This is normal. This is how normally it looks. This is a picture. Emotional pen కనిపించలేదా? Okay. Red choose చేయనా మరి? Okay, this is yellowనే అంటే వైట్ మీద కనిపించట్లేదు. ఓకేనా? ఎల్లో చూస్ చేసా. ఎల్లో కనిపించట్లే అంటున్నా. ఈ వైట్ మీద రెడ్ వాడతాను. This is your stomach. As you can see here, this pinkish mucosa is all normal. और यहाँ पे in gastritis what is happening? It is turning very much red. It's called hyperemic. And यहाँ पे you can see one erosion or you can call it as a gastric ulcer. And because of that continuous reflux happening, even esophagus भी मार खा रहा है. So even esophagus is developing an esophageal ulcer. Okay. This is a healthy mucosa, and this is how the gastritis or gastritic mucosa looks like. So this is colostomy. So whenever you put the stoma outside, a part of the ileum outside, that's how you connect this stoma back to it. This is how normally it is supposed to look. It is supposed to look pink. It has to be properly perfused. You shouldn't see any kind of varied changes around in and around this intestinal part. So after colostomy or creation of stoma, if you see any kind of a purple black discoloration of the stoma, it will indicate that the blood supply to that stoma is being compromised. So what is the stoma undergoing? It's undergoing a necrotic change, and you have to address it immediately. Okay. What are the mechanical intestinal obstruction? What do you mean by intestinal obstruction? There's an obstruction anywhere in the intestine, and there are varied reasons for it. One of the reasons is adhesions. Okay. Second reason is intussusception. I will show you pictures for everything. And then you have volvulus, and then you have hernia. What are adhesions? Adhesions are loops of intestine which are adhering to a slowly healed area or a scar. So usually adhesions are very commonly seen in TB patients. If you, I'll show you the picture. So this is adhesion यहाँ पे. You can see now this is one lumen and this is second lumen. Between So between these two, there are adhesions. All these are all adhesions. There was some kind of a corrosive change here or some kind of an ulcer which has healed, and both, because all these small intestines are very nearby to each other, both are stuck together during the healing process, developing a fibrous tissue kind of an adhesion. So whenever you have an adhesion, that intestine can undergo some kind of an obstruction. And the second reason is again here herniation. As you can see, this is a abdominal wall, and you have a weakening here. Okay, so ये sac में all this intestine is getting herniated into the sac. So this is herniation. Even this can lead to obstruction because यहाँ पे you have the opening of the sac. That can be narrow. If it is narrow, it can undergo a strangulation kind of a hernia, which is an emergency. And then you have volvulus. Volvulus nothing but twisting and turning in its own axis, and it will lead to knots. This is volvulus. And whenever this twists, if this area has undergone some kind of a very tight knot, the blood supply to this area of the intestine will get compromised, and this can undergo obstruction initially, followed by necrosis because the blood supply to that area can get compromised. This is intussusception. Intussusception is the whole tube. So imagine this is the tube. That upper part of the tube is going into it. The wall of the intestine folds inwards towards it. It's called telescopic folding. This is how it looks. You can see that this is 1, 2, 3, 4, 5. This is a telescope. Just imagine, just take example of 5 and 6. So this 6 जो है ना, it will infold into this 5, and that will cause obstruction. And this kind of an obstruction is called intussusception. It's called a telescopic movement. So adhesions, loops of intestine adhere to slowly healing areas or a scar after the abdominal surgery. Intussusception is a telescopic movement of one part of the intestine into the other. The same wall it's going inward. Okay. Volvulus is bowel twisting and turning around itself. Okay. Herniation is protrusion of intestine through a weakened area of the abdominal wall. Peptic ulcer disease. I think I've already explained about this before, a bit about it. You've already learned about it. Anyways, we'll do it again. It's an erosion. Ulcer. Ulcer matlab discontinuity of the epithelium. Any kind of discontinuity of the epithelium is called the ulcer. It is the erosion of the mucosal wall of the stomach, the duodenum, or in the esophagus. It can occur anywhere. Based upon the location, it is also called as esophageal ulcer. If it is in esophagus, it is called esophageal ulcer. If it is in stomach, it is called gastric ulcer. If it is in duodenum, it is called duodenal ulcer. These three areas are very commonly involved because acid is what which is leading to this peptic ulcer disease, especially if there is H. pylori infection in the stomach. This can also cause. So, which are the two structures which are nearby to to the stomach? Up above you have esophagus, and below you have the duodenum. So, all these three areas are vulnerable for developing peptic ulcer disease. And peptic ulcer is more commonly seen in duodenum. Causes are H. pylori infection. This is one of the main infections. NSH can also cause because increased acid production leads to peptic ulcer. Having a lot of coffee, if people are smoking, okay, excessive alcohol intake, all this can also lead to peptic ulcer. What is the management? You'll give a histamine blocker like ranitidine or cimetidine. What is a histamine blocker? These are H1 blockers which will reduce the gastric acid production, finally reducing the effect of gastric acid over the mucosa and allowing the ulcer to heal. And other thing is proton pump inhibitors such as omeprazole, lansoprazole, pantoprazole. All of you know about this. So these are called proton pump inhibitors because day in and day out people have been using this, and it is used to suppress this acid production. Then you have sucralfate. So sucralfate is also called as a cytoprotective drug because it forms a layer over the mucosa which doesn't allow the acid to come and attack the mucosa. Okay, you have to avoid mixing all these three together. Either give one therapy or two therapy, but not you don't give PPIs and sucralfate together. That's not advisable. Then you have to avoid smoked foods, avoid smoking, avoid alcohol use, caffeinated beverages. So only coffee, a lot of coffee and chai can also lead to peptic ulcer. So this is how ulcer actually looks like. Okay, this is your stomach, this is esophagus, this is stomach, and this is your duodenum. यहाँ पे in this duodenal area you can see duodenal ulcer. In this area you can see gastric ulcer. This is the pyloric area. Through this, the chyme, CHYME, the food mixed with all that acid enters into the duodenum. So all that food is very acidic. Okay, so this area is also very vulnerable, and this is the most common area involved. Your duodenum. Duodenum ulcers are most common peptic ulcers. And then the ulcer can occur in the esophagus. It's also called as esophageal ulcer. This is how it will look. You can see there is no continuity of the epithelium like how it is here. It's a discontinuity. You can easily see one hole here. If you leave this ulcer untreated, it will end up into perforation leading to peritonitis. Imagine all that acid getting spread into your abdomen. The patient will enter into shock and it will cause, that will be an emergency. Helicobacter pylori is the causative agent for chronic gastritis. Most common site of the peptic ulcer, I already told you, it is the first part of duodenum. Curling's ulcer. What do you mean by Curling's ulcer? Curling's ulcer is a type of gastroduodenal ulcer. So it can be in stomach or it can be in duodenum. This is caused by complication of the acid burn. Okay, it is due to stress induced and decrease. Whenever if people have take a lot of stress, even those people are very vulnerable to develop this curling ulcers. What happens the moment you take a lot of stress? The mucus secretion decreases, and this increases the effect of the acid over the mucosa, leading to ulcer, which is also called as curling ulcer. There's something called dumping syndrome. It's a complication after a gastrectomy. I'll go in detail later on. And then what are the surgeries for the ulcer? You have Billroth surgeries. Okay, Billroth may have Billroth 1, you have Billroth 2. I'll show you pictures. Billroth 1, just remember that you're removing that part. Mostly lower part of the stomach is vulnerable. That pyloric area of the stomach is vulnerable to develop an ulcer. So if you have an ulcer there, you remove that part of the stomach, which also reduces the acid production. You're removing that part, and the remaining part of the stomach, you're connecting it to the duodenum. That's called gastroduodenostomy. Okay. And what is Billroth 2? यहाँ पे you're ignoring the duodenum. You're connecting the stomach directly to the jejunum. So it's called gastrojejunectomy. Duodenum comes first, then comes jejunum, then comes ileum. You know, everybody knows this anatomy part. HCl secretion is increased with use of milk, caffeinated beverages, smoking, and tobacco use. So even milk, tell the patients to avoid milk and milk products. What is the blood supply to the GI system? It is supplied by arteries originating from the abdominal and thoracic aorta. Okay, so you have three main things which supply the blood. First is the celiac branch. I've already told you, remember these three names: celiac branch, superior mesenteric artery, inferior mesenteric artery. Each one supplies different parts of the first part of the gut is supplied by celiac trunk, followed by the second half of the gut, which is supplied by, also called as mid gut, which is supplied by superior mesenteric artery, and then you have the hind gut, which is mostly supplied by the inferior mesenteric artery. So stomach is supplied by gastric artery, the name itself says, which is a branch of the splenic artery. So a splenic artery, the artery which supplies, it's a main branch coming out of the celiac trunk. It goes to the spleen, and this splenic artery gives a branch to the stomach called gastric artery. And small intestine, the ileum, the duodenum, uh, below the ampulla of water. Okay, वहाँ से you have supplied by the superior mesenteric artery. Till the ampulla of water, it is by the celiac trunk. Superior mesenteric artery gives rise to its branches and all, and it supplies the ileum, the jejunum, okay, and also ascending part of the colon till the splenic flexure, and anterior two-thirds till like two-thirds of the transverse colon. वहाँ तक superior mesenteric supplies. After it, inferior mesenteric artery takes its route. Okay, and then superior artery. Okay, superior mesenteric artery branches. Colon may you have something called superior artery, which is right colic and middle colic branches, and inferior mesenteric artery also supplies, that is left colic and sigmoid. So coming more towards the descending colon, it is by the inferior mesenteric artery. What is a venous drainage? Venous drainage is unique because the venous blood from the GI organs merges to form large vessel. I've already told you all this is nutrient rich blood. They come collect together to form a portal vein which goes to the liver. Where liver say you have this hepatic veins and then finally drains into the SPC, uh, superior vena cava. Okay, because after entering into superior vena cava, that's when it enters the systemic circulation. But before that, you have this connection called portal vein. Okay, nutrient-rich blood in the portal vein enters the liver, which undergoes a detoxification process before it enters into the general circulation. Gastric and duodenal ulcers. Again, coming back to the ulcers, usually if you take age and gender in consideration, incidence. So age usually, first of all, it occurs more in males than in females, and age 50 or more. Okay, in that age, it is very commonly seen. Agar if they are like young, if they are like 30. Okay, in between 30 and 60 years, it is 2 is to 1 or 3 is to 1. Just remember that's a male predominance. So usually if they age way too much, like they've crossed, ladies have entered into the menopause. So in that case, you have no protective drugs in the women's body. So what happens is generally the ratio kind of becomes 50-50, 1 is to 1. After menopause, women become very vulnerable to diseases which are very predominant in male before the menopause. Okay, so menopause makes us almost equivalent to males, and even women who have already attained their menopause are equally vulnerable to such diseases. But remember, it's generally the male predominance here. And what are the clinical manifestations? Depending upon the type of ulcer, there are little differences in the symptoms. So imagine a patient comes to you and says, Doctor, whenever I eat, I develop pain. So you have to suspect that this ulcer is in the stomach. So because whenever the food comes to stomach, it's called, I'll tell you. I don't think that division is being given here. Okay, कोई नहीं. Clinical manifestations, we'll just discuss the general manifestations here and then I'll tell you the differences. Firstly, clinical manifestation में क्या रह सकता है? Either you have normal secretion of acid or you can have hyposecretion also. And then you have something called weight loss because whenever the patient eats, okay, if the patient says, I have relief from the pain, then it is a duodenal ulcer. Okay, and such patients tend to put on weight because they find relief after eating food. But if the patient says that if I eat, I'm developing pain, okay, then it is gastric ulcer because acid is getting produced there. Okay, that such people avoid food and they lose weight. So it depends upon type of ulcer. So either they can be weight loss or they can gain weight. And usually pain occurs 30 to 60 minutes after a meal. This is about gastric ulcer, okay. And what these patients do, they vomit it out. They vomit the thing out because all that acid food has to come out. The moment it comes out, they have relief. Ingestion of food may increase the pain or decrease the pain according to the type of ulcer. Then you something, okay, these patients vomit it out, or generally that kind of burning sensation or reflux. A lot of patients tell, no, along with the acidity, they say that I feel nauseous. They want to vomit it out. So you can have vomiting if there is sometimes if it is too progressed issue, then they can also have blood in the vomiters, which is called hematemesis. हाइपरसेक्रेशन हाइपरसेक्रेशन में क्या रहता है, दे मे हैव वेट गेन, ठीक है, when pain occurs 2 to 3 hours of eating, this patient wakes up in the night due to pain. Okay, ingestion of food may decrease pain. Vomiting is uncommon because after eating the food, the pain is going down, na? So they will not have vomiting. And melina is common in such patients. जिनमें relief आता है खाना खाने के बाद, after eating food, if they have some relief, there is no vomiting. There is melina. They can have bleeding from down. Then chances of perforation are also more in this type, and rare possibility of malignancy. H. pylori in this IARC classification of WHO, it is being classified as a class 1A carcinogen. It means that it causes cancer in the humans, and this has been studied in the humans. That's what class 1 means. So that's the only bacteria which has been classified as a class 1 carcinogen. Bleeding from, okay, GI bleeding. Now we'll talk about bleeding. Bleeding from any part of the GI system is known as GI bleed. What are the causes? We just learned about peptic ulcer. That is one of the causes. And then you can have esophageal varices. And then there's something called diverticular diseases because of the diverticulitis. Ulcerative colitis can lead to bleeding, and tumors. All these can cause GI bleeds. What are the signs and symptoms? Usually, if they're vomiting, they can have frank blood, or they can have coffee colored vomiters. Okay, bloody, maroon colored, or black and tarry stools. Black, sticky, tarry stools is also called as melena. So, you're either vomiting out blood or having blood in the motions. Anemia, in case of chronic GI bleeding, can occur. So, this patient has been having bleeding since a long time. There's loss of blood. So, loss of blood can also cause normocytic normochromic anemia. Treatment depends upon the location. Depending upon the type of disease, accordingly you will treat. And you can also do a gastric lavage if there's too much of bleeding occurring. And there's something called Sengstaken Blakemore tube. I'll show you how the tube looks. It is to control bleeding. So it is like a balloon-like thing, which causes whenever you inflate that balloon, it causes pressure over the walls from where the bleeding occurs. So what do you do if you have a cut on your hand? You apply pressure. The moment you apply pressure, that area undergoes clotting and the bleeding stops. It's the same phenomena which you're applying inside. So you pass this tube into the patient. Depending upon the area, वहाँ पे you will inflate this balloon. The Sengstaken Blakemore has two balloons. The first long balloon is your esophageal balloon, and नीचे छोटा सा balloon you have round balloon. It's a stomach balloon. So depending upon the area, you inflate that particular balloon, and that area, it causes that inflation causes pressure over the area which is bleeding, and at the end we achieve hemostasis. Cauterization or endoscopic injection of sclerotherapy also can be done. So you can cauterize the area. You can do cautery of the area of that bleeding vessel. You can actually cauterize it, or you can endoscopically inject sclerotherapy. You can do that also. Finally, causing the area to achieve hemostasis. The final thing what we have to achieve is to stop bleeding. That's the final goal. All these things can be done. And the Sengstaken Blakemore is mostly used for esophageal varices. So this is how the tube looks. This tube has undergone varied modification. This is one of the simplest pictures that I felt that this will be easier for you. So this is an esophageal tube. ये वाला. And this is your chota wala is your goes into your stomach. So once you inflate, the first bulb or the balloon to inflate, this is your stomach because that is way down. That first inflates, followed by the esophagus. The first to deflate, okay, is your esophageal. Okay, jumping into MRI, it's a non-invasive technique which uses magnetic fields and radio waves to produce images. We are not using X-rays here. We're using magnet here. It is used to evaluate abdominal soft tissue. So it's not meant for bony things. Anything we are supposed to study about the bones, there is a use of X-ray. So we see bones more specifically in our X-rays followed by CT scan. But MRI is meant for all soft tissues where water content is more. MRI is contraindicated in patients with permanent pacemaker. So any kind of metallic devices in the body, it is contraindicated. If the patient has a permanent pacemaker, the patient has an artificial heart valve, implanted with defibrillator, or if that patient has implanted insulin pumps or any kind of metal devices, rods and all this in the body, then you can't do an MRI for that patient. So you tell the patient to be nil mouth 6 to 8 hours before the procedure. You'll remove all the jewelry and metallic things from the body before doing this procedure. If this client is claustrophobic, this is repetition of slide. If he has claustrophobia, you'll sedate the patient and you'll inform the patient about this loud knocking sound which occurs during the procedure. What is gastrointestinal motility studies? The name itself says gastrointestinal stomach, esophagus, intestines का motility, peristalsis देखने के लिए. Liquid and solid component of the food mixed with radionucleotide markers. You ask the patient to, after ingestion of the food, this patient is placed under the CT scanner where you can actually see the peristalsis. This measures the rate of passage of the radioactive food out of the stomach. कैसे pass हो रहा है? How fast it is moving out. This procedure is done to study the gastric emptying and colonic passage time. Coming back to dumping syndrome, I already told you that dumping syndrome is uh, what occurs as a complication of a Billroth surgery. Okay, so you have done that. You have removed a part of the stomach. You have connected the remaining part to the jejunum or the duodenum, as it is, and in that, these patients can develop something called dumping syndrome. Occurs when food moves from stomach to intestine too quickly. It is one of the major complications of the patients who underwent partial or complete resection of the stomach. The symptoms occur because of rapid distension of the jejunal loop, anastomosis stomach. So this happens after you have done Billroth 2. So what you're doing in Billroth 2 is that remaining part of the stomach, you're connecting it to the jejunum. You bypass the duodenum. Directly the food coming from the esophagus goes into the stomach and immediately dumped into the jejunum. All that non-digested or semi-digested food has accumulated in the jejunum. Jahan pe it can cause a lot of gases. It can cause problem in the jejunum because not digested, and jejunum is not the area for digestion of your food. So that can undergo rapid distension and that can cause discomfort to the patient. The patient will complain of abdominal fullness, pain in the abdomen, okay. Hypertonic content in the intestine. So whenever this acid-rich food enters into the jejunum, क्या होता है whenever the concentration of this food is more than the surrounding fluid, all that fluid will enter into the compartment leading to increase in the size of the lumen. So this hypertonic content in the intestine draws fluid from the extracellular circulating volume to dilute the content in it, and also it causes distension. This is what is happening in dumping syndrome. So this food leaves the stomach quickly. इतना सा ही stomach बच के immediately the stomach is connected to the jejunum. This intestine ends up swelling. All the fluid is entering along with this food. Once this food enters, it will attract all the extracellular fluid into the lumen and causes distension. So these patients will immediately after eating, they will say that they have abdominal distension, they'll have pain, fast heart rate, okay, because all that fluid is suddenly going into the intralumen loop. From extracellular compartment, it is going inside the lumen. They'll have sweating, they'll have nausea, they might develop diarrhea and vomiting. Okay, all these are all symptoms of dumping syndrome. So you have sensation of fullness, weakness, faint, they'll feel dizzy, they'll have palpitations, they'll have diaphoresis. Diaphoresis is excessive sweating, cramping pain, diarrhea, and borborygmy. What does it mean? It is called large gurgles, which you can hear, which indicates hyperperistalsis. Okay, this excessive peristalsis can be heard. Patient education to prevent dumping syndrome is firstly they have to avoid sugar, salt, and milk, all the whites, ask them to avoid. They have to eat high protein diet, high fat, but low carb. So I told you, avoid all the whites, eat protein and fat in excess. Eat small meals, and after they have had their meal, tell the patient to not lie down. Okay, they have to uh, they're not supposed to lie down after eating, and they are supposed to avoid consuming fats. Okay. We'll ignore the last point. But what dumping syndrome says is खाने के बाद एकदम नहीं सोना है. Okay. Eat avoid all the whites. Eat more protein rich and fat rich food, but all are in small quantities. Okay, in regular intervals. Don't have it just don't dump everything together at a time. Appendicitis, if they're feeling dizzy, you can tell them, to lie down not completely in supine position, but in a position which, usually if there is dizzy and all that, what happens is once this fluid all suddenly enters into the lumen, the extracellular compartment loses its fluid. So this all can manifest into all this above issues, the dizzy, faint spells. So if they're standing, definitely they'll find it more difficult. So you tell the patient to slightly be in the supine position so as to avoid those dizzy spells. That I think that is what is meant here. But anyways, I'll review this point again and I'll get back to you in the next class regarding this. Appendicitis, the name itself says, is an inflammation of the appendix. Appendix is a small finger-like projection which is attached to the cecum below the ileocecal valve. So wherever you have the ileum entering into the colon, or you can say ascending colon, that is where you have your ileocecal valve, or just below it you have this appendix, this vestigial organ. Okay. Usually appendix has no function in our body. It's a lymphoid organ. Okay. Fecolith. What does fecolith means? The name itself says. Lith is nothing but stone. Feces is all that stony feces which has formed is called fecolith. It's the most common cause of appendicitis. That is what can lead to appendicitis. Most commonly it occurs in adolescents. Clinical manifestations are they'll have low-grade fever, nausea, vomiting. They can have rebound tenderness on palpation at McBurney's point. What is this point? So if you draw a line from the umbilicus to the anterior superior iliac spine of the pelvic bone, there is a line. Okay, from that umbilicus, two-thirds, or from the anterior superior iliac spine, one-third area, just in between. That is where you'll have your McBurney's point. And whenever you actually palpate and you remove your hand, there's a rebound tenderness. Whenever the abdomen comes to normal, after you palpate and remove your hand, it comes down to its normal position. That's when the patient will shout in pain. That's called rebound tenderness, which occurs at the McBurney's point. That is very important. What is Rovsing sign? If you palp, all the abdomen is tense because of this inflammation. Okay. So if you're trying to palpate on the left side, this is all right-sided, right? Appendix is on the right. So when you're trying to palpate on the left lower quadrant, paradoxically, normally it is not supposed to occur because appendix is not on the left side, but it elicits a pain in the right side. That's because of tensing of the abdomen. So this is a very rough diagram. This is your ascending colon. This is your transverse colon. This is your descending colon. Here you have your sigmoid colon. Okay, this is your rectum यहाँ पे नीचे, and below that you have your anus. And this is your appendix. This vestigial organ is your appendix. यहाँ पे you can clearly see this ileum is entering into the colon. And here you have your valve. And that valve के पास you have this appendix. That's indication for us to search for the appendix. There are different positions in which appendix can be seen. Okay. This is your umbilicus. And यहाँ से this is your anterior superior iliac spine. You're drawing a line. Two-thirds from the umbilicus is where you have your McBurney's point on the right side. So once you do palpation on that area, first of all, the patient will not already touch his abdomen because he's in a lot of pain. But if you are doing that examination and you suddenly withdraw your hand, that rebound tenderness occurs. That is positive in appendicitis. This is Rovsing sign. Even Rovsing sign is positive. Appendix is on the right side. Right pe hai. And you're palpating here. You're doing your palpation here, putting your hand on the left lower quadrant. Pain will be felt on the right lower quadrant. This is Rovsing sign. Assessment and diagnosis. What do? You'll do a blood test. Everybody knows क्या करते हैं appendix में. You know that WBCs will be raised because it's an inflammation, it's an infection. Abdominal X-ray you will do. You can do an ultrasound or you can also do a CT. All that will indicate appendicitis. Complication is perforation of the appendix can lead to peritonitis. Before that appendix undergoes perforation, you're supposed to remove of that. Hence, mostly the management here in appendix is removal of that organ because the organ has actually no use in our body. So you'll do a appendectomy. Ectomy is removal, the removing of that inflamed appendix. Okay. Talking about ultrasonography or you can say ultrasound. So, what does ultrasound do? It is using sound waves. High frequency sound waves are passed into the body structures and they come back. Ultrasonic echoes are recorded on the oscilloscope. This is something talking about the ultrasound. Ultrasound requires non-ionizing radiation. There's no ionizing. Even in MRI, you don't have that ionizing radiation. Okay, there is no noticeable side effect because there is no ionizing radiation. Disadvantages: it can't examine the structures lying behind the bony tissue. So if something is behind the bony tissue, these bones will obstruct. Patients fast for 8 to 12 hours before the test to decrease gas in the bubble. If ultrasound is to be done to study gallbladder, fat-free diet in the evening, you tell the patient to have a fat-free diet because if you have excessive fat, na, all that bile and bile salts are required for fat metabolism. So all that will get secreted into the duodenum and the gallbladder will become empty and you cannot visualize it. So you want it nicely full, bulky, filled with that bile juice. Then you will tell the patient to have a fat-free diet in the evening, and then you'll ask him to come nil by mouth. Mostly for gallbladder, all the gallbladder ultrasounds are done in the early in the morning. You tell the patient to come in the morning, empty stomach preferably. If ultrasound and barium studies are planned on the same day, then you have to conduct ultrasound before the barium study. Just same like the MRI and the CT. Okay. Otherwise, barium will interfere with that sound wave. H. pylori, I already told you, it's the only bacteria classified as class 1 carcinogen by WHO. IARC is the classification's name. What does it mean? Class 1 means that this is being very commonly seen in humans and this is the one which mostly leads to the carcinoma. Okay. Gastric balloon is the first inflating balloon. So whenever you're passing gas, that gastric balloon jo hai na, at the end, that round thing, that is the one which inflates first in the sense taken plate module. And the esophageal balloon is the first to deflate. First deflating wala is your esophageal. Deflate matlab you're removing off that gas or you're deflating the balloon. The patient with appendicitis usually exhibits rebound tenderness at McBurney's. It's also called as Bloomberg sign. Rovsing sign is by palpation of the left lower quadrant and the patient feels pain on the right quadrant. It's called positive Rovsing sign which is associated with appendicitis. There's something called upper GI fibroscopy or esophageogastroduodenoscopy. It's also called as ERCP. Most of you know what ERCP. I've always heard MRCP, ERCP. So ERCP का full form is esophageogastroduodenoscopy, endoscopic retrograde cholangio. Sorry, this ERCP is endoscopic retrograde cholangiopancreatography. I'll show you how it looks. They'll pass one fiber optic or fibroscope into the lumen of the intestine and this comes and waits at the ampulla of water. Okay, वहाँ पे you can see this exchange. Like you can appreciate if there are any kind of gallstones in the bile duct or if there are any kind of pancreatic stones, any issue at that common duct. Okay, at the ampulla of water area. I'll show you the picture. So fibroscope is it's a flexible tube with fiber optic lenses which allows the visualization of the esophagus, stomach and duodenum. Side viewing flexible endoscope is used to view common bile duct, hepatic duct and pancreatic duct through ampulla of water in the duodenum. It can be used for both therapeutic purposes and also to diagnose. After the patient is sedated, the fibroscope is lubricated with jelly and slowly passed through the tube. So this is how it is finally reaching. So you can see this is pylorus. You can't see it. This is pylorus. This is the fibroscope which we have passed, and it has finally entered into the duodenum. Okay, यहाँ पे यहाँ पे you have the camera. This is the ampulla of water. यहाँ पे you can see this is the common hepatic duct and this is the bile duct. Both join to form common bile duct, and common bile duct is again joined by pancreatic duct here. This is pancreatic duct. This is common bile duct. This is the fibroscope. This is common hepatic duct. This is bile duct. Okay, anyways. So you can see all that yellow, gold, silver thing, that is nothing but stones. If near the bile duct, in that sac, that pear-shaped sac, which is the gallbladder, is the stones inside the gallbladder. And here, near the ampulla of water, what you can see is the stones which are blocking the common bile duct. Okay. So यहाँ पे patient is wearing a mouth guard because he'll end up biting that tube, na? So you don't want that. So there will be a mouth guard, and you'll ask the patient to be nailed by mouth for 6 to 12 hours before the procedure. Atropine may be given to decrease the secretions. If there are too much secretions, it can obscure the view. Sometimes glucagon may be given. It relaxes the sphincters. Left lateral position pe you'll tell the patient to sleep, and after that you'll sedate the patient. Okay, even before and after the procedure. After the procedure, the patient will be advised to eat or drink after the return of gag. When you can feel the gag here, then you'll tell the patient to drink or eat after the procedure. Post-procedure complications, what can happen? You're passing a tube inside. So perforation can happen. If the tube hits one area of the mucosa, there can be a small nick and bleeding can happen. Elevated temperature can happen. Okay, difficulty in swallow. So this is how the patient is sleeping on the left lateral position. This is the mouth guard through which to this hole you will pass the fibroscope. Fibroscope. Then coming to peritonitis. What is peritonitis? We're coming back to it. Itis is inflammation and peritoneum is getting involved. Varied other reasons like perforated ulcers, any kind of fecal matter entering into the intestine, or anything which bursts into the abdomen, it causes peritonitis, and usually these patients will enter into shock. So management is you'll give the patient fluid and you'll give colloid and electrolyte replacement. That's a major focus of the management. You're giving more fluids. Then, because of the distension of the abdomen, there is a raised intra-abdominal pressure, and that can compromise your lung expansion. So you have to see that the breathing of the patient is normal. Usually, it is compromised, so you put the patient on oxygen therapy. If necessary, you can intubate. Okay, and then there is a lot of infection. You have to put them on IV antibiotics. You'll give them antibiotic therapy. Usually, a broad spectrum antibiotic is selected. Surgical management is needed if the peritonitis occurred as a result of appendicitis or as a result of perforation. You have to repair the perforation. If appendicitis is a reason, you have to remove that organ. So, whatever it is in such cases, you go ahead with surgery. Peritonitis patients are placed on the side with the knee flexed. Why? Because if they're sleeping supine, all the abdomen is tense and they feel way too much pain. They cannot sleep like this. They have to be on the side. All that abdomen has to be lax. So whenever you fold your knees, all that abdomen becomes more loose, and usually they'll have slight relief from the pain. Stress. It's a huge word. It can be physical stress or it can be psychological reaction to a real or a perceived threat. Stress reaction increases cortisol, which is nothing but glucocorticoids and mineralocorticoids levels are increased by which are produced by adrenaline in the blood. Okay, prolonged physiological stress responses may contribute. If there is a prolonged physiological stress, it can lead to gastric ulcers, decreased immunity, infections can occur, renal failure can occur. So much things can occur because of stress, and it will result in damage to the body, resulting in problems such as kidney failure, okay, gastric ulcers, and aggravation of the existing illness. The term stress was first used by an endocrinologist called Hans Selye. Okay, general adaptation syndrome is the three-stage response that the body has to stress. So there is some. I'll show you the picture. ठीक है. Surgical management of the choice for peptic ulcer is total gastrectomy or removal of the entire stomach, and some portion of the esophagus is attached to the below duodenum or the jejunum. And or you can have Bilroth 1 and Bilroth 2. In Bilroth 1, that remaining part of the stomach is connected to the duodenum, and in Bilroth 2, that remaining part of the stomach is connected to the jejunum. So, if you're removing of the whole stomach in total gastrectomy, you're attaching the esophagus. If you're attaching it to the duodenum, it's called esophagoduodenostomy. If you're attaching it to the jejunum, you're calling it as esophagojejunostomy. Along with this, you can also do a vagotomy because vagus is what is just controlling the acid secretion. So, removal of the vagus nerve supply to the stomach, you decrease the stimuli for the gastric acid secretion. So once the vagus is denervated or removed, what happens is secretion of the gastric acid will come down. You can also do gastric resection, removal of the lower portion of the stomach, usually along with vagotomy. It is also called as anthrectomy. Anthem is an above part of the stomach. So you're removing just a part of the stomach here. Anthrectomy is, I'll show you. If this is your, you can't see this word. So if this is your stomach, यहाँ पे आता है your antrum followed by your pylorus. So that part is removed in anthrectomy. Wilroth, I've already told you, we're doing a partial gastrectomy, antrum निकाल दे रहे हो, and you're connecting it to duodenum, where it's called Wilroth 1. If you're connecting it to the jejunum, it's called Wilroth 2. And Wilroth 2 can lead to dumping syndrome. Okay. Reconstruction after partial gastrectomy, the duodenal stump is closed. That's in Wilroth 2, and gastrojejunostomy is created. What is pyloroplasty? Pyloro is pyloric area, you're doing something, plasty. But enlarging the pylorus. This is to prevent that pyloric obstruction, and you'll increase the gastric emptying. If there is a hypertrophic pyloric stenosis, matlab in that pyloric area there is a stenosis, there is a narrowing of the lumen, then you have to do this surgery to release that pressure, allowing the food to actually enter into the duodenum. This is Bilroth 1, first picture. Second picture is Bilroth 2. Coming to pyloric stenosis, this will be our last topic for today. Okay, major clinical manifestation. This is one of the major clinical manifestation. काफी common है. So what do you do? यहाँ पे what is the catching thing for you? Firstly, they'll have a pain. So if you're telling the patient to swallow something, you can actually see some kind of peristalsis, and that will make that stenotic area or that pyloric area to become more prominent, and you can appreciate it more towards the epigastric region or the right-sided hypochondric area. वहाँ पे you can see, ठीक है, olive shaped mass की तरह दिखता है, olive shaped. So in this patient, because bile duct is not opening before the pylorus, it's opening after the pylorus. So any kind of obstruction at the pyloric area will lead to vomiting, which is non-bilious. There is no bile being ejected out in that vomiting. Dehydration can occur because you're constantly vomiting, and constant vomiting can lead to electrolyte imbalance. Olive-like mass on palpation on the right upper quadrant of the abdomen. Left to right peristaltic movements is observed across the abdomen. It is very prominent. Investigation is physical examination. What are the radiological examinations you can do? You can do an ultrasound or you can do an X-ray. X-ray film mein, you can see a strange sign in the X-ray. I don't have the picture for it. I think I forgot. Anyways, so this is your normal stomach, and this is your pyloric stenosis stomach. So you can see how narrow this lumen is. This area is all hypertrophy, and you can actually feel it whenever the patient tries to swallow something. Whenever you give a little bit of milk or something to the baby, you can see an olive-shaped mass on over the right upper quadrant of the stomach. Okay. What is the management? You have to relieve this. You do something called as pyloromyotomy. यहाँ पे you're causing a nick in that area of that hypertrophy. Nick मतलब small longitudinal cut on that area, and you're relieving that spasm. It's called Ramstead procedure. मतलब all that muscles is all hypertrophy. You have to relieve it. Once you relieve it, na, all the tight muscle will slightly loosen up, allowing this all tight like this. The moment you give a nick, it will loosen up. So that's called Ramstead procedure, dividing the muscle of the pylorus to open up that outlet. Diverticular disease, I've already told you, it's pouch-like bulging in the GI tract, also known as diverticular disease, and you have to surgically remove this diverticulum. It is causing a problem. Colostomy, I told you, it's a temporary management of the condition. Once you've removed a part of the intestine, it has to heal. So what you'll do, you'll get that part outside on the tummy, and you'll attach a stoma back to it. That's a temporary management till that internal part heals, and then the patient might undergo another procedure where the intestinal anastomosis takes place. Okay, guys, thank you so much for being with me today. From 180, we'll be doing it tomorrow. So remember this point. Good evening, Dahlia. What H stands for? H is Helicobacter. Helicobacter pylori. That is the name of the Helicobacter. That's the name of the bacteria. It's called Helicobacter pylori. Thank you guys and have a nice day. We'll see you. I'll see you tomorrow again, mostly at the same time. 3. Okay. Thank you.